I want to welcome you to this Learn at Work webinar hosted by the journal Work, a journal of prevention, assessment, and rehabilitation. I'm Karen Jacobs, the founding editor of Work, and I will moderate today's webinar. It is with great pleasure that I introduce Cynthia Abbott-Gaffney, who will be presenting on telehealth in school-based practice, viability to bridge global OT practitioner shortages. Cindy, I'm going to turn it over to you now. Thank you.
Thank you so much, Karen. It's great to be here. Thank you for having me today. As Karen shared, my name is Dr. Cynthia Abbott-Gaffney, and I am a full-time professor at Temple University in Philadelphia, Pennsylvania, in the occupational therapy program there. And I am part-time faculty at Boston University. Today, I'm presenting on a study that I conducted while doing my doctorate at Boston University on telehealth. And it's interesting to share that this occurred before telehealth was really big on the scene, before the pandemic. So it will be interesting for me to take this walk down memory lane. But a little bit of background about me first. I graduated with a master's in occupational therapy from New York University. From there, I worked for Moss Rehab Hospital in the Drucker Brain Injury Center for almost 15 years. And there I worked in every point in the continuum of care, as a case manager, as a clinical OT, as a programs manager, and then later as a programs developer and clinical administrator. After about 15 years, I decided to become an OT independent consultant and contractor in school-based practice. And I primarily worked with individuals who were transitioning either from middle school to high school or from high school into adult life. And I did this because while working in the community reentry program at Moss Rehab Hospital, we began to receive a lot of referrals from individuals who were aging out of the public school setting and needed services to facilitate community skills and life skills. And doing this in a clinical setting, in a clinic-based setting, was not the most effective or efficient way to do this. So I started working as a contractor in school settings to do this. And it was during this time that I gained my first exposure to telehealth and became really interested in how much more efficient we could be if we were able to incorporate telehealth into some of the work that I was doing. It was at that point that I decided to pursue my doctorate at Boston University. I was just absolutely blessed and delighted to have Karen Jacobs as my academic mentor, and we worked together on this study. And shortly after graduation, I took on the full-time faculty position with Temple University, where I remain now, and happy to be a part of the faculty at Temple and Boston. So a little bit about my journey to telehealth. Necessity is indeed the mother of invention. And I've included a picture here, which includes my grandmother and a family that I met on vacation. And what do these two things have in common? Well, I had an experience with my own family where we had a family member who was receiving hospice services. And it was very difficult waiting for healthcare professionals to arrive at the home when things were really challenging. And I remember sitting there thinking, wow, there's so much that we could do and take care of if we could just connect now for 5 minutes with one of the healthcare professionals instead of waiting for them to arrive in 6 hours or tomorrow. But my family member lived in a rural area. There were not a lot of practitioners available, and so the wait was quite lengthy. Similarly, this is a family that I met. I do have their permission to use this photo when on vacation, and they shared with me that they had a family member who required school-based OT services, but a similar experience. It was very difficult for their district in a rural area to get and keep OT practitioners. I became friendly with Mom, and we stayed friends after vacation, and I began chatting with her by FaceTime, offering some ideas for school-based OT intervention. And it worked. We were successful working together. And this had me thinking more about how many other individuals around the country were unable to receive OT services because of the OT practitioner shortage, particularly in rural areas. And came across this article from the New York Times. This is from 2017, where it was a big issue for getting enough practitioners to meet the IEP needs. And from there, it launched my investigation into OT practitioner shortages, not just in our nation, but globally. And this became the focus of my doctoral process. And so I was looking at the potential to use telehealth services to try to bridge some of these gaps. And I was familiar with how telehealth could be helpful. I had incorporated it into my own practice, but I found that there was significantly decreased adoption of telehealth. Now, remember, this is before the pandemic, and I wanted to explore that further. So looking at the state of affairs with our great profession of OT, back in 2018, employment of OT practitioners was projected to increase by 24%. OT services were reported to be in demand in all regions of our country. In 10 regions in the United States, there was a considerable shortage of OT practitioners, and by the year 2030, it was predicted that there would be a shortage of OT practitioners in 50 states. I investigated a little further. 39 countries reported shortages of OT practitioners, which is really considerable when we see that 15% of the global population is living with disability and 5% of children globally are living with disabilities. So then I took a look at the evidence of efficacy and comparative effectiveness with telehealth. And I found that there were a lot of positive outcomes for rehab services with hip and knee replacements, post-hand surgery, cognitive impairments, mobility impairments, upper and lower extremity impairments, and connected with a variety of needs: traumatic and acquired brain injury, MS, Parkinson's, cerebral palsy. And indeed, there was comparative effectiveness with services delivered by telehealth when compared to those delivered in person. And so a big theme of what I'm going to talk about today is this is true when telehealth is delivered appropriately, when it's used in an informed way. And in many instances, when we are not in the middle of a crisis and being required to switch everything about our practice to telehealth, while simultaneously switching everything about our lives. And that's what we saw a lot of during the pandemic. But prior to the pandemic, we saw that there were effective outcomes that were at least as effective as in-person services in treating mental health issues, spinal cord injury, chronic conditions in rural communities. And in 2009, so this is way before we started to broadly think about implementing the use of telehealth, an analysis of 28 studies revealed that there was comparative effectiveness between telehealth services and in-person services. And of those, at least 13 of those studies were considered to be of high quality. Now, there was a 2015 limited survey of OT practitioners about their perceptions of using telehealth, and there were very few positive perceptions. With telehealth experiences, there was decreased telehealth utilization, and most importantly, and this continues to be a theme today, reduced self-efficacy with the use of telehealth technology. And so I had enough information at that point to sit down and sketch out a model that explains the problem. There was a national and global shortage of OT practitioners, and this resulted in gaps in the delivery of school-based OT services. And it was projected that this could be offset by the use of telehealth. However, with limited evidentiary support and training available for OTs to draw from, it was very difficult to have a widespread adoption of telehealth. The comfort level with its use could not be achieved. This was before the pandemic. And this led to limited opportunities for OT sessions to occur for students with IEPs so that they could acquire the performance skills necessary for successful participation in educational occupations. This led to decreased occupational engagement in school settings, which of course leads to a decreased overall health and wellness for students in the school setting. So I felt as though it was my responsibility to investigate further and spread the word about how we could successfully bridge this gap and offset this problem. So I used the diffusion of innovation theory to guide my doctoral efforts. And the diffusion of innovation model or theory states that perceptions about an innovation, in this case, telehealth as a delivery model, by the adopters, in this case, OT practitioners or those people who might use telehealth, the perceptions are even more important than the actual innovation, right? So how practitioners perceive telehealth is even more important than how good telehealth options actually are. And more specifically, perceptions of relative advantage. Why should telehealth be considered in addition to, as a supplement to in-person services, or in some instances, when it's appropriate, instead of in-person services? The complexity of telehealth. How difficult is it to use? And we certainly learned during the pandemic that there are a lot of barriers to navigate. And as I found with my research and continue to find in using telehealth today, they can be navigated, but the appropriate amount of time and effort and resources have to be available to support practitioners in navigating those complexities. Compatibility. Is telehealth compatible with the type of services that OT practitioners are trying to deliver? And a quick answer there is yes, and we need to be mindful of how we are delivering services, right? It's not always going to be possible or feasible to offer hands-on interventions in the way that we do in an in-person setting. So we have to employ the use of coaching strategies and to make telehealth compatible for environments, have the availability of an e-helper, parent, caregiver on the other end to support what we're trying to do, and we have to be able to communicate what we're trying to do successfully so that it can happen on the other end. Observability. Is there a way to allow practitioners to observe successful telehealth sessions in progress before they have to buy in to the use of a platform, right? And if you are a practitioner who pivoted to telehealth use during the pandemic, you are probably thinking, yes, there was no opportunity to consider any of these things. We just had to do it. And that was really challenging for the majority of practitioners. And then trialability. Per Rogers and the Diffusion of Innovation model, practitioners need the time and opportunity and resources to trial an innovation before they are expected to adopt it. And again, that did not happen for the majority of practitioners during the pandemic. So again, prior to the pandemic, I developed a program called the OT Telehealth Primer for school-based practice. I'm going to tell you a little bit more about how it was developed and how it was implemented. So first, again, it was important to investigate and gather evidence from early adopters. That is a term, again, used in the diffusion of innovation model. OT practitioners who began incorporating the use of telehealth in their practice early on, as well as gather evidence from potential adopters, OT practitioners who were unfamiliar with telehealth but might be potential users. And then once the evidence was gathered, structure this into the OT Telehealth Primer for school-based practice, including information on the attributes of telehealth, why it's appropriate in this setting, how the complexities can be navigated, how it can be compatible, but most importantly in the training program, offer opportunities to observe telehealth and try parts of telehealth without fully adopting. So the OT Telehealth Primer for school-based practice was based on data collected from 2 surveys. The first survey was OT practitioners who were new to telehealth, and we collected data on their familiarity with and their perceptions of benefits and barriers to using telehealth. The second survey was for OT practitioners who were experienced in telehealth use and exploring their experiences and perceptions of benefits and barriers as well. Now, participant recruiting occurred from using closed social media sites, a variety of sites on Instagram, Facebook, LinkedIn. The survey itself was powered by Qualtrics software. And we did receive IRB approval to run the studies from Boston University's IRB. And then once the data was collected, I used it to develop the OT Telehealth Primer for school-based practice and made this course available for OT practitioners who had not used telehealth yet, using a platform called Blackboard Course Sites. If you haven't used it and you have the need to develop a training program, I get no kickbacks. I have no connection to them, but I do recommend it because it's free for you and your course and for users. And so I developed a 90-minute training program. I included a pre and post-training survey. The program consisted of 5 modules. And the first module included basic telehealth terminology and getting the word out there that there were already positions taken by the American Occupational Therapy Association and the World Federation of Occupational Therapists. Fun fact, shout out to the World Federation of Occupational Therapists, Dr. Karen Jacobs and I and Jana Kaysen, Tammy Richards and Abbott-Gaffney just recently updated the position statement on telehealth for the World Federation of Occupational Therapists. So do head over there and check that out. That's a free resource that's available on their website. But back in the beginning, again, pre-pandemic, just getting the word out that there were established guidelines out there already for using telehealth. The second module included information on licensing, reimbursement, ethical considerations, privacy considerations, and this was all quite new to a lot of practitioners at that point in time. Beginning with the stay-at-home orders during the pandemic, many more practitioners needed to become familiar with these concepts. Then the training covered equipment, setup, and internet requirements for using telehealth, research findings, appropriate uses and inappropriate uses of telehealth, as well as seeing telehealth in action. So the training program included actual interviews with the video footage with OT practitioners discussing the benefits and barriers that they had experienced, as well as actual sessions with permission so that potential adopters of telehealth could see what it looks like to use telehealth. And so we also included findings from the surveys so that we could have a well-balanced information on what OT practitioners felt like they would need to become comfortable and confident using telehealth technologies. And we also included some information on using the coaching model when offering telehealth services. So the study was a systematic, mixed methods, quasi-experimental participatory action research study with surveys designed to obtain both quantitative and qualitative data. There were survey questions that had fixed responses as well as open-ended responses. Responses were anonymous, and the survey was set up so that participants could complete these on their own timeline. Some of the survey questions were adapted and expanded from a study conducted by Rortvet and Jacobs back in 2018. And some of the questions with fixed responses used a Likert scale. And we were really looking at the likelihood of the participants adopting telehealth after completing participation in the program. The open-ended questions helped us explore the perceptions of benefits and barriers more deeply. We also collected demographic information. And so we conducted a data analysis with descriptive themes. We tracked the frequencies of benefits and barriers. And we also used a quantitative analysis to look at the fixed responses as well. Now, there were some limitations, of course. This was a pilot program, so the length of the program was 8 weeks in total. There were 43 participants who completed the pre-survey, the training program, and the post-survey. And we also identified notable themes that were important for future research. Now, with the OT practitioners who were experienced in telehealth, the early adopters, 100% of them identified as OT practitioners. And here we have their years of experience as OT practitioners, with the greatest percentage being between 15 and 30 years, more than 50%. And then in terms of years of using telehealth, we can see that the majority of them had been using telehealth between 1 and 3 years. So for the early adopters of telehealth, they were already clear on their perceived benefits. Service access, where services were not otherwise available. There were a lot of themes related to improved collaboration, communication, consultation, and carryover with all team members. And I feel like it's important to highlight that we are going to see, and we are already seeing a lot of studies that speak to the contrary on experiences of a quick pivot to telehealth during the pandemic. But it's important to underscore that in most cases, it was not a well-trained, well-informed, with opportunities to practice, right, trial and observe telehealth when practitioners were forced to make a quick pivot to using telehealth during the pandemic. So I am optimistic and believe that these perceived benefits are accurate and that we will see a return to these being the reported benefits once individuals who continue to use telehealth are able to do so in a more informed way with better practice. We also saw themes with increased productivity, with scheduling flexibility and reduced travel as our most frequently mentioned benefits. Now, if you look at the numbers on the perceived barriers, they're pretty low. It looks like there are a lot of barriers, but the frequency at which these were reported is pretty low. The biggest one being internet can sometimes be unreliable. We continue to experience that to this day. And we certainly experienced a lot of that during the pandemic. The concept of hands-on assistance not being able to be provided by the OT directly, as well as technology challenges and an e-helper sometimes being unreliable, but which really speaks to the need for being able to use our best coaching methods. So if we look at now the reported perceived benefits with telehealth. Now this chart is showing us the responses for OT practitioners who had not used telehealth, who participated in the training program, and the blue bars show us their responses before they participated in the training, and the red bars show us their responses after they participated in the training. And so in all areas, we're able to see that the benefits significantly increase after they participate in the training, including access to OT, collaboration and carryover, efficiency and productivity, organization of evidence and materials, reduced costs to schools, and students' engagement and comfort. So our next chart is showing us experiences for the OT practitioners who had not yet used telehealth, but completed the survey pre and post training program. And we see that all of the barriers decrease. So we have pre-training barriers in blue, post-training barriers in red, and we see that all areas indeed decrease. And some completely went away after participating in the comprehensive training program. And then there were some areas that were identified as areas that required future development, internet reliability being one of the largest, the lack of the OT practitioner's ability to put hands on, distribution of materials and maintenance of materials used in sessions, the standardization of evaluation protocols, and licensure portability. And so we've seen a lot of information become available over the last year as, again, necessity being the mother of invention, it was required that we navigate a lot of these themes. So there are not perfect protocols out there yet. They have not been completely navigated, but we have seen a lot of improvements. So the most important question, was there an increase in likelihood of adopting telehealth from pre to post training? Yes, there was. So that was good news. Although we went in with a high percentage of participants who reported prior to completing the training that they would likely adopt telehealth after completing the training. And yeah, that's one of the limitations of the program. We advertised and recruited using technology, which suggests the likelihood that our participants were individuals who were already comfortable to some level with technology. So it wasn't a statistically significant increase, but nonetheless, it was an increase. So in conclusion, this study was published in October of 2020. We identified that there was a well-documented national shortage in the US and globally of OT practitioners, that telehealth offers a way to begin to remedy some of the service delivery shortage. We're certainly not suggesting that telehealth should replace in-person sessions, but it's a powerful tool that there are many benefits to using telehealth when it's used well and when the practitioner is informed and has the time necessary to prepare and is able to secure materials needed both by the practitioner and the clients. That there's, prior to the pandemic, literature demonstrated that there was limited adoption of the use of telehealth. And that the OT Telehealth Primer and completion of its pilot yielded a high likelihood of adopting telehealth when comprehensive training in its use is available. The dissemination of the post-training program findings on the perceived attributes holds promise to expand telehealth use into the future. And again, it's my hope that that will continue even post-pandemic. And with increased adoption of telehealth for the delivery of OT services when used appropriately and trained properly, it can indeed contribute towards improved availability of OT services globally. So this slide just shows the publication that was published by Work Journal back in October of 2020. And just an interesting note, Karen Jacobs and I had no idea when we ran that study and created that program how useful it would become. And so this slide is just sharing the variety of outreach that we were able to participate in. The stay-at-home orders in the United States began during the second week of March 2020, and by the third week of March 2020, Karen and I began offering free of charge webinars to help OT practitioners become informed on the use of telehealth. And to date, we've done 25 global webinars. We've reached individuals in more than 78 countries. At times, we had more than 10,000 attendees. We've authored 2 publications on this work. As I mentioned, co-authored the revised position statement on telehealth for the World Federation of Occupational Therapists. There's a third study that we're currently in the process of completing data analysis on, and we are hoping to contribute towards the development of best practices for the use of telehealth in the delivery of occupational therapy services. It's also humbling and exciting that Karen and I have been invited to coach therapists in the Brain Injury Association of India in the use of telehealth for neuro rehab services. At this time, they are still dealing with stay-at-home orders, so individuals are not able to deliver services, which means our patients are not able to receive services. So we are humbled to be involved in this project, hoping to navigate some of the barriers with telehealth use to get services out there. So in terms of moving forward, it's important to reflect on the quick shift that had to happen to telehealth during the pandemic. Many practitioners did so with minimal or no training. And so we're going to see varied perspectives on telehealth use and experiences. So ongoing training and development of best practices is going to be very important. And so with that, Karen, are there any questions I can answer?
Cindy, I don't see any questions from our attendees at this point. Attendees, if you could put your questions into the chat box, that would be wonderful. But let me ask a question of you too. And it's a joy to work with you, first of all, and so much has been accomplished and more. Can you maybe give us a little bit more detail on what you're doing at Temple? You have a website there as well. Could you go into more detail on what kind of resources are there?
Yes, so I am so proud of my colleagues and just blessed to be working with such a great group of faculty members. I'm working with Dr. Erica Pugh, Dr. Jeannie Coviello, Dr. Anne Marie Murphy, and at the beginning of the pandemic, we were finding that there were a lot of clients in the Philadelphia region who were not able to receive telehealth services. And we also had fieldwork students who were pulled from fieldwork sites almost immediately there was just so much change and so many moving parts at that point. So we partnered with the speech and hearing clinic at Temple University and began offering telehealth OT services free to community members who were not able to participate in rehab services during the stay at home order. And during that time, we offered coaching to students and practitioners who were offering those services. But something really cool happened. Many individuals who were receiving services were willing to give consent to allow us to record parts of their sessions, and we were very careful not to record anything that was too sensitive in nature. But we are using this footage to help identify different occupations that can be successfully addressed through telehealth for different populations, as well as demonstrate, right, thinking back to the diffusion of innovation, observability, what exactly does that look like in session? So we continue to work on editing these videos of actual sessions to put up on the Temple University OT telehealth website, which also includes a lot of resources or just links to other sites that have comprehensive resources for telehealth. So it's been a very meaningful project. We continue to offer the services through the telehealth clinic, and it's been a great way to conduct services, training, and research on OT interventions and telehealth, and involve students and faculty and our community clinical education partners as well.
Cindy, thank you. And it sounds like it's been something that's meaningful to the recipients of the services, your faculty and students, as a wonderful way of providing more experiences in telehealth. So a question I'd like to ask is what's sort of next in projects that you'd like to do? You mentioned the one that's forthcoming, starting next week with the India Head Injury Association. What else are you thinking about doing related to telehealth?
Great question. Telehealth has the potential to be a really powerful tool. I think the thing that I'm most interested in and most excited about is making sure that we collect the necessary evidence and get it out there into the literature, disseminate the information on best practices for telehealth, for assessment, for coaching caregivers, family members, educators, as well as develop comparative effectiveness in more specific interventions. So there's a lot of information available right now. And most of what I'm finding is about just overall incorporating telehealth into practice. But the specific protocols that work best, we're starting to see them emerge, but I'd like to really see those develop more. So we're actually working on a research study now at Temple on the delivery of an executive functions intervention by telehealth, and measuring the success there. We're also looking at comparing in-person administered evaluation tools to evaluation tools delivered by telehealth. So there's a lot of exciting directions to go in. Karen, as you know, you and I have worked with Ono Academic College in Israel and have done coaching with OT and PT practitioners there to, again, disseminate the information that is helpful in developing best practices for OT. The project with India, I'm so excited about, because what we've learned is the individuals that we'll be assisting are not receiving any services or any kind of contact at all. And many are in some of the most impoverished areas of India. And so we're working together to navigate some of the barriers with technology and Wi-Fi and, of course, training. So a lot of exciting directions to go in. Cannot stress enough, never hoping to replace in-person services with telehealth, but hoping to improve continuity of care and the efficacy of services that are delivered.
Cindy, thank you. And our attendees, please, if you have any questions for Cindy, please post them in the chat. And Cindy, it is really a joy to have you published in the journal Work and all the collaborative activities that we've done. You're a leader in this area globally, and it's very exciting to have the opportunity to work with you and for the journal Work to have published your manuscript from your doctoral work at Boston University. So, Cindy, any last thoughts before we conclude?
I think only two. First, right back at you. It's been an absolute pleasure and honor to work alongside of you. And we've done so much in the last year. And we certainly did not see this coming when we designed this many years ago. So thank you for all of your leadership, both with telehealth, but in the profession as a whole. And I guess my parting thought is if you've tried telehealth and your experience was not as positive as it could have been, please don't close out the idea forever once the pandemic ends. Let's work together to develop best practices and to navigate the barriers. And if there are specific barriers that you continue to experience, I would love to hear about those. And I can be reached at cynthia.abbott-gaffney@temple.edu. You can certainly also reach out to Karen Jacobs at kjacobs@bu.edu because we want to hear from you. We want to hear your experiences, and we want to take the steps to make the improvements to make it better and to better our profession and proliferate our profession and the use of this powerful tool in doing so. So Karen, thank you so much for having me today. I really appreciate being here.
Oh, thank you so much. And everyone who's joined us, thank you for our Learn at Work webinars. We've been having these ongoing webinars, which are complimentary, supported by iOS Press, the publisher of Work. We have a Learn at Work YouTube channel where you can listen to all of our previous webinars. So once again, thank you. And Cindy, thank you so much.
Thank you, Karen.